Hello and welcome to the Doctor's Corner. I'm your host as always, Dr. Mark Pinsky. And in case you're wondering, yes, we have been gone for quite some time, but we are back now better than ever. I'm happy to report new staff, new crew, totally new executive producer, Jeremy Gonzalez of Spectaculoso Productions. So happy to have him along with us, and it's been a wonderful ride so far. I think you'll be excited to know the new content that we're going to do, and a lot is going to depend on you, the audience. We want to hear from you. We want you to actually email us, drmarkscorner@gmail.com, or you can contact us via our website at pinskywellness.com. That's pinskywellness.com. We'll also probably wind up doing a Facebook, Twitter. We'll be everywhere. But for now, those are your two main sites, drmarkscorner@gmail.com and pinskywellness.com. We want to hear your input so that we can create shows which are in your best interest, things that you really are interested in knowing about and want to hear from us about. Again, we've been gone for a long time, but we are so excited to be back in our own studio, and we look forward to bringing you many, many hours of entertainment pleasure. So welcome back and enjoy. Welcome back to the Doctor's Corner. I'm your host, Dr. Mark Pinsky. Alongside me, Dr. Mark Hanley. Mark, welcome to the show. Good to see you. We're going to talk today about breast cancer. One of Mark's specialties is not only the diagnosing of breast cancer, but the treatment of breast cancer. Let's talk a little bit about your background, Mark. Where did you come from? Where did you grow up? Where did you go to school? Give me all that.
I'm originally from Ohio. I grew up in Akron, Ohio.
I forgot about that. Yes.
And then I went to Bowling Green State University for college, and then I went to the Medical College of Ohio, and then I did my surgical training at the University of Florida.
So let's talk about breast cancer. Number one, how do you go and diagnose breast cancer?
Let's explain a little bit what breast cancer is.
Sure.
And essentially, breast cancer, it's a malignant epithelial tumor that grows in the breast. And it does harm by traveling to other places in the body. And it travels one of two ways. One is through the lymphatic system, which generally goes to the axillary lymph nodes, and one is through the blood system, which can go anywhere in the body. And then it usually takes up residence there and destroys that organ. Mm-hmm. So that's just an overview of what really breast cancer.
Right. So let's give the age ranges that you would do a screening mammogram on.
Screening mammogram, we would start at the age of 40. Generally, our ages of 40, just because the breasts are very dense when we're very young, meaning there's a lot of dense tissue, and the mammogram's not very good at picking up abnormalities because the tissue is so dense. And as we get older, or as women get older, the breast tissue then gets more replaced by fat, and fat shows up nicely on the mammogram for us to see some abnormalities.
Okay, so what age do you normally do that up to?
The current recommendations is if somebody's life expectancy is, you keep doing it until it's no longer more than 10 years. Okay. I have a problem with that because how do you know what somebody's life expectancy is? So as long as someone is highly functional or even functional, I think people should still be getting mammograms and screening tests, because the biggest risk factor for breast cancer is actually age. Number one.
So that's kind of interesting, because that goes right along with my philosophy. I mean, you and I have known each other for 20 years. I've sent you literally probably by now thousands of patients. And we're still talking to one another, which is a good sign. But one of my philosophies has always been about functionality. And I always believe that if a person's functional, chronology doesn't make a darn bit of difference. And, maybe I'm a little biased because my mom's 83, but she's very healthy 83. And so I don't know how much longer she really has, to live. And so I'm a big believer in that, exactly what you just said. So does it matter what the age is in terms of how frequently you do the mammogram?
I still recommend once yearly. Right. You will see some data that's coming out every 2 years. You know, most breast cancers are in the breast 2 to 4 years before we ever pick them up. They actually grow very, very slowly. And the problem that I see a lot is a lot of the radiologists, they're great at reading films, but they're not great breast clinicians. And what I mean by that is 6 months, they'll give a lot of recommendations if they see an abnormality and say repeat the mammogram or repeat the ultrasound in 6 months. Well, to be perfectly honest with you, 6 months in the grand scheme of breast cancer is not long enough. Right. So a lot of times what I'm trying to do, if there's something questionable, we biopsy it and move on and get them back to yearly. Right. Is my recommendation.
Right. So what's interesting is the way the recommendations come down. They always say 1 to 2 years. That's what the recommendations. It makes a little more sense now that you say that the average cancer is there for 2 to 4 years. But from a primary care perspective, it never made much sense to me as to what I would prefer to do. I always have my ladies screen themselves every year. And I do that starting at the age of 40. Now, I know some people would say that starting at the age of 40, you can go every other year. I'll tell you why I don't do that. In our profession, what you do, you get skewed based upon what has happened in your own history with your own patients. And so tragically, I've had a couple of cases of really bad breast cancer very early. And as you know, in the 40s, when you get breast cancer, it tends to be very aggressive. And I don't like to do it every other year because I'm always afraid of missing that breast cancer. So do you agree with that, or?
I do. Definitely yearly screening. I also think, and for years we've always mandated that, or recommended that women do monthly breast self-examinations. And I'm still a big proponent of that. I'm kind of old school.
Me too.
Some of the newer data says don't do that because we're finding things that we don't need to find. And we're doing unnecessary procedures on women that don't need to be done. But however, 15% of all breast cancers don't show up on a mammogram or an ultrasound. So I've had women come into my office where the mammogram and ultrasound is normal, and they're like, Mark, I feel something in my breast. Right. And some doctors, primary care doctors, will look and go, well, the mammogram and ultrasound's normal, therefore there's nothing there. When in fact, yes, it still can be a breast cancer.
Right. So there's a little caveat for you ladies out there. It is imperative that you examine your breast every month. Now, we always tell women that we'd like them to, if you're still having your cycle, it's better to do it the first week after your menses because that's when your breasts are the least dense and it's easier for you to feel things, correct?
Correct.
All right. So I'm old school, I'm an old guy now. So I'm still a big believer in all of that. And I have had several patients find their own breast cancer. So I'm a big proponent. You're only going to see me once a year, or you're only going to see your gynecologist once a year, and that may be a waste of time if you're not doing it every month. So I agree with you. Mammogram, great at picking up microcalcifications, but not great about picking up lumps. So let's go there. You diagnose yourself. In other words, you're the patient. You find yourself having a lump. You can't get into your primary care physician, not my patients, but other primary care physicians, for another 6 weeks. What do you do?
Well, I would, number one, I would have a mammogram or some kind of diagnostic test. Number two, I would call your regular doctor and mention that you feel a mass in your breast. And either you'll come in and you'll see your doctor, or you can be referred to a general surgeon. Or somebody that treats.
And I think the problem is you need to push that. As the patient, you need to push that, because if you feel something, the person at the front desk may not understand your urgency, may not feel your urgency, but sooner or later you have to get to someone, whether it be your gynecologist or your primary care physician, who's going to be able to either see you and or refer you to somebody like Mark, who's a professional in this area, who can really... And Mark's very good about being expeditious about it. I mean, he will get you in. So if you really find a lump and you can get to the right sources to get to him, he's going to make sure that everything happens the way it's supposed to happen, because time is of the essence here. Now, I don't want to freak everybody out or paranoia you, but the fact of the matter is time is important when it comes to identifying any kind of cancer. Correct.
Correct.
All right. So let's just say that you make the diagnosis you have a lump, and you get referred over to Mark. So let's take it from there. Mark, what are you going to do once they get referred to you?
First, do physical exam, see if I can feel the lump, make sure that we don't feel anything else. Generally, I check the lymph node basins, which are typically underneath the arms. I'll personally review the images on the mammogram or the ultrasound, and then usually what we do is we'll proceed with a biopsy. And a biopsy is just taking a little piece of that tissue, and there's one or two ways that we can do that. First is a stereotactic biopsy, and that's usually done with when we see changes on the mammogram or microcalcifications or some kind of changes that we don't really feel, and it's usually very small in size. And essentially what happens is we put the patient on a table, and they're actually laying face down, and the breast kind of hangs below the table. And the mammograms or the stereotactic table is able to locate where the calcifications are. And then we just numb up the skin a little bit, and we wheel this into its location, and we typically do a vacuum assist biopsy where a needle goes in, and it's a rather small needle, and it kind of sucks in all the tissue around it. We take it out, and then we put a little marker clip in there about 1 millimeter in size. You can't feel it, and it just says, hey, this is an area of the breast that was biopsied. And then we give the specimen to a pathologist who reads it microscopically and tells us what
we need to do.
Yep,
right.
correct.
Let me tell you how important that whole process is, right? So the clip itself gives them an idea so they don't have to chase all over the place if, God forbid, you have to go back and have this done multiple times. And I do have patients where we follow them, and we followed them now for years, and sometimes nothing ever shows up, and sometimes that's the exact location. It was just too early to find. You know, we're limited by what science allows us to do. So unfortunately, science doesn't take us to where we want to go,
Right.
but we maximize what we can do to be able to provide the best patient care we possibly can. Correct?
Correct.
All right, let's switch gears a little bit. This is one of my favorite topics with you is male breast cancer, right? Because the notion out there is that breast cancer is exclusively a female disease. And Mark and I share a patient who came to me via his dermatologist because he had nipple discharge, and that nipple discharge was bloody. And, you know, right away I know that means breast cancer until proven otherwise. Regardless of the fact that the guy was 80 years old, regardless of the fact that he was male, it didn't matter. That is absolutely a reason for somebody like Mark to be involved in that case to make sure that that's not breast cancer. In other words, we want to make sure, we'd rather err on the side of caution and make sure. And so that case is a perfect example. It was breast cancer. Mark did a marvelous job. I can't even tell he was there. Removed the cancer. The guy is doing tremendously well on follow-up. This is a couple years now, and he's doing tremendously well, and we anticipate that he'll do fine for the remaining days of his life. So talk a little bit about breast cancer in terms of males. How prominent is it? How often do you see it? And what's the process about going about treating it?
So male breast cancer, it does occur. It's 1 in 5,000 men get breast cancer. So women, it's one in 8 women over their lifetime will develop a breast cancer. 1 in 5,000 males, and typically it can be a bloody nipple discharge like you described, or usually it's a lump that they feel underneath their breast. And then we simply do a workup with it, including a mammogram, usually on a male, and we will biopsy it and essentially surgically treat it, just like it.
Just the same way, right?
But 1 in 5,000, so not near as...
Yeah, but still, I mean, I don't think that anybody, including myself, every time I hear that number, I'm like, well, that's not really an insignificant number. I mean, it's quite a few men that are probably walking around who haven't been treated.
Correct.
And so we should pay attention to that as well. Anything I forgot? Is there anything that we would need to talk about with regards to breast cancer in women that women should really know more about?
Risk factors. Okay, we kind of touched on that a little bit. Number 1 risk factor, again, is age.
Right.
Okay. Family history is also a big risk factor. We now have some genetic testings that we can do regarding the BRCA genes, and there's numerous genes. So basically, all breast cancer is genetic, and people will say, well, nobody in my family ever had it. Well, it's still genetic. We haven't isolated all the genes, but for the most part, it's basically all genetic. And then usually when we have 3 relatives or first-degree relatives and they've been tested and BRCA positive means essentially by the time a woman is 80, there's an 80% chance she will develop a breast cancer.
So are there labs readily available to do that? I mean, my patients are very proactive, so they go out and they find their way of doing this, and they find all these labs. Is there a specific place you send people, or is there any place that you know of?
No, we do. First, we see if someone's a candidate for that and see how the family history kind of lines up, and then we typically do it in the office. And a lot of times, it's just a mucus swab right in the mouth.
Right. So you don't suggest doing that routinely.
No.
Okay.
No.
So this is what I see. This is what I hear all the time. So the BRCA testing and genetic testing is a very valuable tool, but he uses it as an adjunctive tool to, and you know, you and I were taught this because we're old now, but you and I were taught this in school and through our old training that honestly and truthfully, we don't just go to testing. You still need to do your physicals, still need to do your great history, and that will guide you as to who really needs genetic testing, correct?
Correct.
Okay. What else?
High-risk screening, if somebody would fall into that category, we would change it. Basically, at the age of 25, if somebody is high risk, we will start with an MRI. And an MRI of the breast is the most sensitive test that we have for picking up breast cancer. However, its specificity is not as great. And what that means is it finds basically all the breast cancer, but it also finds things that we don't need to open a Pandora's box, if you will. And we will chase things that are essentially benign. But so for a high-risk group, at the age of 25, we start with an MRI of the breast. And then we wait till about the age of 30, and then they can start with a mammogram. And typically what we'll do is every 6 months we'll alternate an MRI with a mammogram.
Okay. I was always wondering who really qualifies for an MRI and who doesn't.
I use it. I mean, I think number one, you should be seeing a breast surgeon or a general surgeon regarding that, and I will use it on a physical exam where I'm not sure that if I feel something or if they think they feel something and the breasts are very dense and it doesn't, show up there, I will go to an MRI, or if there's something else questionable, I'll use it. But you have to be careful. It's getting better with time, but it's not 100.
Well, I think that's the biggest problem. You said there's false positives, that what happens is it creates us to chase things that we don't really need to chase. I think probably where it's gained the most notoriety, though, is in women who've had implants, correct?
Even mammograms are great for the implants. There's still, I wouldn't say an MRI if you have implants. It wouldn't.
Really?
Yeah, it wouldn't.
Because I remember a long time ago that if a woman had an implant, the fear was that if they did the mammogram that they would rupture the implant.
Correct. Now, if you're worried about a ruptured implant, yes, I do order an MRI for that. But typically, we're not too worried about much of the...
So you're not worried about the actual mammogram creating a ruptured implant?
Correct, no.
But if somebody suspects that they have a ruptured implant, you would then do an MRI?
Correct. Or if we diagnose somebody with breast cancer too, I'll do an MRI just to make sure where the size is and make sure that the contralateral, the opposite breast, is 100% free.
Okay. And that makes a lot of sense to me. That does make a lot of sense. Okay, what other topics do we need to cover with regards to breast cancer?
The surgical. We can talk a little bit about the surgical treatment.
Sure, let's do that.
So, essentially, with a breast cancer, as long as it's not locally advanced, meaning it's small, and most of the times when we diagnose them, they are small, we have an option of surgically removing them. And there's 2 ways to surgically remove them. One is just to take out the lump, which is called a lumpectomy. Now we call it a partial mastectomy. And generally when we remove the lump, we also do some radiation. And we will check the lymph nodes underneath the arm via the sentinel lymph node biopsy. So we're just taking one lymph node, 1 or 2, testing them, making sure that there's no cancer.
And is the sentinel lymph node a good parameter for what would be going on underneath the rest of the lymph node or rest of the lymph system?
Absolutely, absolutely. In the old days, we used to just go in and we would
Right,
take
I
out
know.
all the lymph nodes, and women would get what we call lymphedema, where the arms would swell, and there's
terrible.
really no treatment for
It's
it. We
terrible.
would wrap it,
It's terrible.
and it's horrible. Now there's about 23 lymph nodes underneath the arm, and what we're looking for is first one or two, sometimes three, and how we find them is. We inject the breast with a technetium-99. It's a radio-labeled nucleotide, and it travels from the breast to the lymph nodes, similar like a breast cancer would. It travels from the breast to the lymph nodes. And then I also use what we call isosulfan blue. It's a blue dye I use in the operating room, and I inject the breast in, and that blue dye will also go to the axilla. And then in the operating room, I'm able to make a small little incision, and I have a probe called a neoprobe, and it beeps when I start getting close to the lymph node.
I didn't know that.
And it will also turn blue. So I usually get a visual, and I usually get a hot lymph node with the neoprobe, and I take that out and take one or two of them out. Anything that's hot or anything that's visibly that I see or anything that's blue, and I send it down to the pathologist who's waiting downstairs and does what we call a frozen section, takes a quick look at it, calls me back on the phone, usually in about 20 minutes, and says, Mark, it's negative. That means I stop. I do not take any more lymph nodes. If he says, Mark, that it's positive, then I take out more of the lymph nodes.
Right, and we go through this process until we get what we call clear margins.
Correct. Or just that it's once we start in the axilla, we have anatomic barriers we have anatomic landmarks, and we follow those landmarks, and we kind of just clear out that area.
Okay, fair enough.
So that's with. And then the other treatment, of course, is a mastectomy, removal of the entire breast. Right. And usually we have a plastic surgeon that follows me in afterwards and reconstructs the breast if needed. But what's interesting is, the mastectomy and the lumpectomy or partial mastectomy, both treatments, they're equal. One is not better than the other, providing that the lumpectomy or partial mastectomy is followed with radiation. Yep.
Interesting. So they've changed all the protocols. I mean, every time I think I've got it down. They changed the protocols. So that's why I don't memorize the protocols anymore. Ever since medical school, I don't memorize the protocols. I just call Mark, and that's all I just do. When's the time where you feel that the person needs to get an oncologist involved? When do they need to go out of your hands and then go into the hands of an oncologist?
So anytime somebody's diagnosed with breast cancer, whether I make it or somebody else makes it, we have a whole breast cancer team. So right from day one, I'm on the phone to the oncologist, who's a hematologist oncologist who gives chemo or hormonal therapy,
Right.
And then we also have a radiation oncologist if radiation is needed, and then we have a plastic surgeon. So there's four of us that are in constant contact with each other. That's because awesome. Sometimes we'll see. An aggressive or locally advanced or a HER2 positive breast cancer that we will treat with chemotherapy prior to surgery.
Really?
Mm-hmm.
Wow. And they find that the outcomes when you do that are far better than if you did a post?
Not far better, but better.
Better.
And better. And a lot of times we would do it, for instance, if we thought that the breast cancer was too big, for instance, where I couldn't get clear surgical measure that would shrink. That would,
that makes sense.
Make it smaller. And we've seen a lot of complete, clinical and pathologic responses, meaning somebody comes in with a very advanced breast cancer that's visibly, you can see it and you can feel it, and we give them the chemotherapy, and then I go in and I will do usually a complete mastectomy, and there's no residual cancer in the breast.
Wow, that's pretty.
So they get a complete pathologic and clinical response.
That's really, really cool. So let me just, this is kind of off the cuff. I have a special affection for Mark because he's my personal surgeon. He's operated on me a couple of times, and he's just an amazing surgeon. What he said is really the essence of who he is in terms of how he practices medicine. He's very, very patient-centered, not just disease-centered, but patient-centered. And I think today in this crazy world that we live in, most of our physicians tend to be disease-centered. And of course, I try to surround myself with those people who think philosophically the way I do, that the patient is really what matters. We can treat the disease, but if we don't take care of the patient in all of their phases, we have a problem. So I like the approach of having a team. And of course, if it's my patients, they already know that. They know that I'm going to be very involved in their care. But to have someone who's a specialist who's going to be as involved in their care as you are, and to be able to coordinate this team is truly a special thing. And so I assure everybody that anybody that, God forbid, has to go to him for such an event, a tragedy in their life, I think that they're in incredible hands. And I really, I respect you highly. I think you're an amazing doctor, not just an amazing guy, an amazing friend. So I appreciate that. I want to thank you so much for coming on, Mark. Always a pleasure. We'll bring you back to talk about some more exciting things in general surgery. For Dr. Mark Hanley, I'm Dr. Mark Pinsky. You've been watching The Doctor's Corner.